Now, we have two fantastic people here. Fran and Nancy, come out here so people see you. These are our info DJs. Now, you've had a first session this morning, so you're all pretty happy dabbling away on the old keyboards and on the cell phones and iPhones, so do tweet. We had a fabulous session earlier on cancer care. We had tremendous interaction from the audience on the Twitter feed, wonderful questions, and it worked really, really well. So, hey, you guys have a lot to live up to. This is a super session. Okay, guys? Now, you'll have a roving mic as well, so when the questions come, great, super. Okay, well, we have 3 sessions, and our first speaker is up there, Adrian, and Adrian has a sidekick. They're going to do a double act. He's disappeared. He's not disappeared. He's coming back. He's there. All right, okay. You're going to sit back shy and retiring here. You just dive onto the stage midway through? Okay, super. Adrian, ready to go?
Yep, thank you. Now, older person's opportunity for improvement. This morning, Maureen mentioned the whole question of reliability and resilience. So what I'm talking about today briefly is just some reflections on what that might mean, how we might use those principles of quality improvement to manage one of the great challenges, global challenges, is managing of frail older persons. I was on a ward round recently and got to the ward. It was the end of a long day and a long ward round for the post-emergency admissions, and I asked, could I see the patient's fluid balance chart? And the nurse gave it to me and said, it's really good, and boy, was it really good by the standards of our hospital, because she said, that's an acute kidney injury patient, and that's why we're doing such a good job on the fluid balance chart. And I thought back, it was about 6 months before we'd sat in a darkened room, a group of us with the renal physicians, designing our local care bundle for acute kidney injuries. We'd got magnetic Ks for the patient at a glance board, which to mean that people queued into that. And it was just amazing to, not prompted by anything in particular, that actually that had produced that level of traction in the wards, and quite quickly. But equally, that's linear, conventional, totally straightforward, and more to the point, health staff know about that sort of thing. Now, take that patient with acute kidney injury, early in the ward round, a patient with delirium, pre-existing dementia, who came into hospital because of immobility and falls, very sick. How would a mono-component care bundle work for that patient? Well, I'm sure it's self-evident, not very well. And that is the challenge. Add into the challenge, certainly in our hospital, and we take graduates from all of the UK, my question when they all start is, who's heard of the Waterlow scale for pressure sores? And about 10% put their hand up. So we're not even training UK graduates in some of the basic methodology for harms in preventing harm, particularly for older persons. And the same with delirium, which we'll come back to later on. It's about 20% put their hand up to say, I know about delirium. We don't ask them what they know, but they know something about it. So we've got this interesting challenge of, and then you take the older generation like myself, a cohort problem of lack of knowledge combined with complexity where, if you like, the traditional care bundle methodology is a bit of a problem. So what I'm here to talk about is just some thoughts about the challenge of frailty. So it's not being old, it's being frail. Something all geriatricians like myself know what it is, but can't quite tell you what it was. But the sort of strapline is at the bottom, is that minor stresses lead to functional change and or death. So in other words, it's partly defined functionally, and obviously it overlaps there, but crucially, old age, talking about old age medicine, is to some degree not really the challenge. The challenge is of frailty. It's patients with complexity, comorbidity, and functional problems that are close to change. And to some degree, the well-established methodology, very good evidence base for what you do about this in a hospital or a community setting, is comprehensive geriatric assessment. Multifaceted assessment, frail older persons, coordinated stroke integrated response, the cliche right patient, right treatment, right time, which is fine. And most of our work locally in our hospital has been, if you like, based around an initial CGA assessment. But the challenge is you can assess very, very well, but what do you do with the assessment? How well do you actually deliver change? How well do you deliver recuperative rehabilitation in patients such as I described a few minutes ago? And two things, which is the sort of brief theme of my short talk today, is that, you know, do we need to think a bit differently about teamwork? Because communication, shared goals, again described so passionately this morning by Maureen, but shared goals when the patient has dementia and doesn't have any carers, a very common experience in our hospital. But how we get teamworks to really gel around the patients, and to some degree some thinking about probably new methodology, if not new ways of working. So I just want to say a few words about some work we did, and actually this was truly a back-of-an-envelope thing that we invented at an international forum 4 years ago, which has now got to the stage of being one of the 5 enablers, the so-called Amber Care Bundle in the English NHS National End-of-Life Care pathway for acute hospitals. And where this came from was looking at what actually happened to patients who died in our hospital. And you know, variation is the birth of, or the start of thinking about these things. And I did this case review of patients who died. The quality was from the absolutely superb and outstanding to the borderline, actually probably outright illegal, and a whole spectrum of problem. So we took the concept of a care bundle and created what is become the Amber Care Bundle, which, because of this national program, is spread to now about 30 hospitals in the English NHS. And it's really looking, and many but not all of the patients here are frail older persons, but I'm using it here as an example of a new methodology to drive a different way of teamwork. So this group in the middle, the end-of-life care in England and the UK, we use something called the Liverpool Care Pathway, but this group in the middle, where there's an uncertainty about whether the patients will recover or not, which is the time you need to start having planning discussions and thinking about the appropriateness of treatment. So if I can just say what it came, and this all came out of traditional QI, PDSA cycles, is first of all, who are those patients? So some trigger questions there. But this, for the sort of thought today, is the sort of interesting aside. So what ended up in the care bundle was, to some degree, forcing teamwork between medical and nursing staff, better teamwork, better goal setting, better thinking about, and to be honest, for this group of patients, just medical and nursing staff talking to each other about the patients, something that had disappeared a bit from our system. So it was things that you might be terribly depressed, but certainly this is the experience throughout England and a little bit internationally from talk I've got, is a clear medical plan done in a timely way, a clear decision about the appropriateness of escalation and resuscitation, but crucially sharing that with the nursing staff. And then the second thing is a clear advanced care planning meeting between patients, carers, and clinical staff. And so framing just those 4 things, and then followed up, and this is probably because actually so much of this work in areas where people are unfamiliar, which they were here, is could easily be a tick box exercise, but crucially for these patients who are recognized in this pathway, this bundle, a daily follow-up by the ward nurse to say, is everything all right, has anything changed, and so on. And we use this now throughout our hospital. So my experience in ward rounds, it's now a regular event. A nurse will come up to me and say, what about the Amber Care Bundle for this patient? And I think, yeah, you're right, I hadn't thought of that. And it prompts a discussion, a planning meeting, and so on and so forth. And there's just a bit of outcome data where I won't dwell on that. It seems to work and seems to reduce unplanned readmission. In one hospital in the Midlands of England that's using it, for these patients who are discharged, who are approaching the end of life, they've had one readmission out of their first 60 patients because there's a clear advanced care plan agreed with the patient and the carers in advance. So to some degree, that is taking a traditional quality improvement approach, and actually what we ended up with, it wasn't our intention at the beginning, was to some degree a bundle that is driving teamwork, where it had to some degree disappeared from our health system. So, next stage is that frail older person I told you about. So this is some work that is in evolution, some work we're running with the British Geriatric Society, which is, can we take this principle of some sort of checklist and apply it to frail older persons admitted to hospitals. And I'll just briefly say a few words about FrailSafe, as we call it, which is developed as a collaborative effort in 5 hospitals in England, and we're just looking at spreading this across the UK at the moment. And it's very much looking at the acute care quality for frail older persons. And of course, as is self-evident, if you're an older person with dementia and experiencing delirium from a urinary infection, can you design a worse possible experience than our process of acute care, the ambulance journey, the arriving at the ED, the meeting huge numbers of strangers, the noise, the distraction, and so on. So we have many challenges in this area. But just to give you a few lines is to take, and again, this starts from a premise that actually this is targeting at doctors and nurses, health staff, primarily in the acute medical unit setting, where this is not necessarily their core knowledge, or it's not necessarily the priority for what is a very challenging and stressful time. So where have we got to with FrailSafe? Well, first of all, the recognition response. So we've dramatically, because the trouble with frailty is, do you want to have the 2-hour symposium on what it is, and we'd still be discussing it, but doesn't really help you identify the patient. So the first thing is, who was that core group of patients? So we ended up with some very simple stuff, patients who have problems with falls and mobility, confusion, or living in care homes. So in other words, the 30-second check. Step 2, and I still think this is too long, but this is the sort of consensus that's emerged, is some of the key sort of CGA type of points, and there they are, the confusion, equipment, etc., etc. But what all of us felt the problem we were trying to solve was 2 things. One is a better recognition response to delirium, but also this thing that drives delayed recuperation. And all the hospitals we work with experience the same, including our own. The waiting for the physiotherapist to prescribe whether the patients can walk. The lack of integrated recuperation, mobilization at weekends or out of hours. The fact that it isn't integrated into the patient's care plan. Ergo, patients experiencing when recovering from acute illness is prolonged bed rest or longer than it needs to be. So those were really the 2 points of this, and just some other things we chipped in. When we've tested this with junior doctors, and they were making the whinging point, and I thought this is absolutely what we're trying to achieve, because they all say, what do I know about pressure ulcers? And the answer is nothing, because we don't teach them, and that's the nurse's job. And I did think, fantastic, where this will drive a different dialogue for people responsible for acute care patients. Now, one of the issues then with FrailSafe is we come into this thing of confusion, and is there delirium? And you probably can't read this, but certainly not at the back of the room, but it then says, follow local guidelines. So we've got the sub-question of what are the local guidelines. Now, I visited a struggling hospital recently, and it's my standard thing when I do this, find some of the medical staff and said, show me your delirium guidelines. And after about 10 minutes, we got the 70 pages cut and paste from our National Institute of Clinical Excellence dementia stuff, completely unusable and unmanageable. So follow local guidelines, shall we say, for this challenge is probably not going to be good enough. Now, this is where Mark comes in. I hope your mic is working, because this is just to briefly, Mark, some work taking through what we've done in terms of a delirium care bundle, and just some early reflections on that. Mark.
Adrian, thank you. I think one of the successes out of the AMBER was to create a word which the nurses felt empowered and able to raise that issue of around advanced end of life or near end of life. So the same with dementia. On delirium, we had a problem in that people come into hospital not with dementia, they come with delirium. And as you've heard, many nurses don't get taught delirium in undergraduate school, and many doctors don't get taught it as well. So we've created a strapline which is called DAD for Help, which is to resonate with an easy call. And as a consequence, we looked at the literature, and our own guideline has a summary of 2 pages, on which this bundle, and the next slide in a minute that you'll see, and these are bundles of evidence-based from the literature, designed in the kind of typical technology that you're familiar with, a maximum of 5 ticks, which empower and allow either the doctor or nurse to implement a delirium bundle. And the great thing about this one is that this order set, electronic order set, is open to any doctor or nurse. And in particular, nurses recognize delirium easier than many junior doctors. So a nurse can order this and hand it to the junior doctor and say, they're delirious, here's your jobs and here are my jobs. And the great thing about these 2 slides, and we're happy to share this later with you, is that there's very great similarity. And like Adrian mentioned, item 4 on both sides is discuss with the respective profession and the family and care patient. So we haven't shown proof of concept. That's what we're doing now, before and after approach, to see if you implemented those bundles, would you reduce length of stay? Would you improve quality of outcome? Would you improve the experience? But here's our evidence from the rollout of the bundle electronically. Started in August. We've did a revision around December because the earlier version wasn't working, and you've got data out to March. So these numbers are totals by month, and it will continue to rise in April. And this is a marker of people having recognition and driving a response. Our challenge now is, can we implement 100% those tick boxes in the bundles for nurses and doctors? Thanks.
Thank you, Mark. And is it just us, or the fact that in both those bundles we've actually bundleized doctors and nurses talking to each other and sharing goals? And again, Maureen was talking about that, but that's where we've got to in our health professions, that that's an issue. Maybe it was ever thus, but certainly the world is more complex, so it needs that work. The other thing is, note that 30% of medically admitted patients over 65 experience delirium, so we're still way below that. But this is, the problem of lack of education equals lack of recognition. Now, just briefly for a few minutes is just some thoughts on our local South London integrated care programme, which we're running with our stakeholders in King's, and there's a website there if anyone wants to look at the stuff. But just very on the theme of, actually, do we need to think differently about methodology? And we've got an integrated care program. I and groupings from general practice, community health services, etc., we meet together to discuss and reflect on patients. But I think there we have, to some degree, sitting in a room discussing difficult, complex patients doesn't necessarily get you very far. Indeed, my experience so far gets you not far at all, because our program hasn't been designed actually with explicit quality improvement plans. But just to give you one brief reflection on this, one of the things that we kept when we looked at unplanned readmissions of frail older persons was the UTI. And of course, remember, mostly the UTIs aren't UTIs, but that's a different point. So, and what was clear in our primary care setting is there wasn't a systematic approach to secondary prevention of UTI. The basic methodology of what to do wasn't there. So this is something we pulled together actually in about an hour. So in terms of, these are the sort of key things to do. This was our hospital specialist guideline for secondary prevention of UTI. And we're just at a sort of early test phase of this. But just to pick out one thing is assess the residual bladder volume. Fine for us working in a clinic setting with a bladder scanner. So the immediate question from the community matrons is how do we do that in a community setting, or are you going to give us a bladder scanner to play with, being the other thing? But those things, for the patients we review, the frail, housebound older patients, including very basic stuff like not having a trial without catheter, being discharged from hospitals and not that follow-up, is happening all too frequently. So there's a question of how we embed this in a population-based out-of-hospital setting. And the same briefly with, this is the segmentation we have for our falls pathway for fallers, frail fallers in South London. We've had this set up for about 10 years. The point being is the powerful intervention is prescription of strength and balance training, or adherence to prescription of strength and balance training. But how do you, when I see falls clinics around about the UK, what they are top-heavy on assessment. Back to that first point, comprehensive geriatric assessment doesn't help any patients. It's the action linked to the assessment that does. And many of our clinics are top-heavy in assessment and light on actually delivery. So one of the things we're just looking at the moment is taking this into a community population setting. 30% of patients, residents of South London over 65, fall at least once a year. Simple algorithm: is your gait normal? Do you have critical trigger symptoms? And then we refer direct to exercise programs. And working through how we do that on a scaled up population basis is going to be a challenge. But just to say, the immediate challenge, when I presented this to our community matrons, they said, you've got to be having a laugh. You're in South London, in Southwark, and no one has a house big enough to do a timed up and go, which involves 3 meters walk there and back and turning around, partly because it's full of junk. But, so immediately we've got to think different methodology, and which we're working on. So again, that's another challenge. And then finally, I'll leave you with this to think of, that within our integrated care program, 2 value streams are: one, hospitalization, hospital bed days. Heard that from Tayside this morning, so that is where the money is. The other is patients in care homes, and emergency admission from patients in care homes. It's the UTI and also pneumonia are the 2 drives to that. So the question, which we're working early days on this, is pneumonia is largely driven by aspiration. In that care setting, with a semi-casual workforce, how do we take quality improvement methodology, a checklist, a bundle, to prevent aspiration, which involves possibly pretty tight control of feeding and quality control about feeding in that care setting. So that is designing the checklist is easy. I think that's an example of the implementation will be very challenging. Thank you very much.
Thank you very much, Adrian. That was very interesting. I really enjoyed that. I should have introduced myself at the beginning. I'm Donald Macaulay. I'm from the BMJ, but I'm the primary care editor. So I listened particularly to what you were saying in the relationship of primary care and what your community matron said to you. I also heard the bit where you said there's not a lot to be done by sitting around talking about it, but we can talk about that another time. Anyway, we have some feedback from our Twitter. Fran and Nancy, do you want to give us a little bit of feedback on what our Twitter followers are saying? Come on out here, Fran. Come on.
We've got lots going on actually on Twitter at the moment. We've got some questions from people. Everyone's very impressed with the Amber Care Bundle. There's a lot of talk about that. One question from somebody asking about the care bundle. How do you know that for every eligible patient the bundle is being completed? What part of the process do you measure to find out how effective it is?
Well, I think in the sort of trailer to the talk there was things like outcome measures. I mean, I think with where we've got to with Amber, and remember we're working on hospitals all over England and many are working on paper, that's just sort of traditional audit. But with FrailSafe, where we haven't quite got it launched, but through the North West London Clark, which is an academic quality collaborative, we're hoping to run frail-safe domains with online web-based submissions. So in other words, you will get real-time quality data about your own process, and all the other centres you'll be able to see how all the other centres are performing, you can find out who's doing well. But with Amber at the moment, I mean, that's the issue of spread in a lot of hospitals. You have to just go with whatever hospitals can do, and the same with us, it's just periodic audit, I'm afraid. But we hope, I mean, moving the technology, they've run it very nicely in Northwest London for COPD, is there to have sort of real-time feedback and real-time run charts.
Let's have a question from a real person, Fran. Do you want to get ready, the next virtual person? Have we a question from a real person here? Yeah. Well, you were just beaten to the back in a sec.
I'm Siva Putrasingham. I'm a geriatrician from Luton and Dunstable Hospital. Just wanted to ask a question, because if you do not have a geriatrician working at the front end, it sometimes takes 3 or 4 admissions before somebody thinks about aspiration in a frail elderly person. So do you have plans to educate secondary care people as well first, please?
Sorry, was the question about secondary care?
Yeah.
Yeah. Only half an hour. We're delighted to give a sort of 5-day symposium on this. I mean, what I haven't talked about was we've used CGA modelling. We've developed the Geiser Thomases and spread to a number of other hospitals liaison teams. So the medical one we call OPAL, Older Persons Assessment Liaison, but we have liaison teams working in surgery and oncology. So the OPALs, which we've had now for about 10 years, is essentially a consultant geriatrician run multi-professional team assessing all patients who are over 70 admitted using a CGA-based methodology. But note, assessment doesn't equal action. However, a general reflection, and I speak as a geriatrician and lobbyist for geriatrician, is we do have to be concerned. You're talking about the process for the patients, and you could put loads of my colleagues or myself as geriatricians, and we don't necessarily have the right skills to be at the front end dealing with. So in other words, the model of saying you've got to have a consultant geriatrician there seeing every patient as they come in, I would just say, A, it's undoable because there aren't enough of us, but more to the point, think of the process. So in other words, if your challenge is recognition, aspiration, well, in a care home setting, it's probably not that difficult. It's called the patient with pneumonia and do they have impaired swallow? I think the challenge there is the quality back at base in the care setting. But I think, that's another, we don't have time to go on that. I mean, I think liaison models, so I think the thing that most excites and interests us is the benefits we're seeing in surgery and oncology from liaison models, where to some degree, at least there's a modicum of competence in geriatrics, in acute medicine, but shall we say hearts of darkness for those other areas.
Fran's waving at me. We have another. Oh, Nancy. Okay, fire away.
Question here. So there's a question about communication between doctors and nurses that you commented on. So question was, are bundles needed to instruct doctors and nurses to talk to each other? And have we identified actual barriers?
Well, hold on a sec. How many nurses have we in the audience? Yes! Okay.
Well, I should say
you're under pressure here now.
The Amber bundle was developed largely the nitty-gritty by a palliative care nurse. And of course, in a wonderful imaginary world, of course, this would be crazy. But remember, we were starting with Amber, which can the medics make a clear plan? Was step one of that point. So we're starting possibly at a relatively low base. But what one would say with Amber, and I had a visitor from Australia coming to the ward, and I did the rather dangerous thing of just turning up on the ward and saying, talk to whoever you meet about Amber. And the nurses just again and again, described it as, rather than the conversation that never happens, I'm worried, this patient just isn't right, the relatives are really anxious, all that stuff that just never gets stated, is to say, I think this is an Amber patient. Suddenly you have a language you can share. So I would say probably human psychology requires something like a bundle, some sort of trigger that sort of says this is particularly important for that patient. But of course, wouldn't it be nice if we didn't have to do it? But it's needed in South London and probably most of the UK.
Mark, you wanted to come in here just quickly?
Just to reply that in terms of the nurse element of the delirium bundle, in fact, that box was driven by nurses because their perception of junior doctors was that the junior doctors didn't speak to the nurses. So in an attempt to get consistency over a bit of paper, admittedly, that message came from the nursing profession because of their concern about the need to work as one team. So weakness noted, but I guess the reality of at least our practice locally.
And just in our inpatient falls pathway, I mean, delirium is one of the triggers there, and it's largely a nurse-run thing, but the medical task is delirium management, and should we say that's the thing we've consistently had the lowest quality on in our falls work. So it is a problem, and it's back to, if we don't teach medical students about delirium, etc., you're going to have a problem. So an education challenge as well.
Thank you. Now we have one final question.
Thank you for your comments. I'm David Moores from Edmonton, Alberta. Would you care to comment on the strengths and weaknesses of the handover that occurs when this frail elderly person comes home? And it's likely I'll be doing a house call in the next 24, 36 hours. What are the strengths and weaknesses of what you experience?
Well, I think UK and particularly South London contexts could do hugely better, and it is a problem, but getting better. I mean, we run a lot more patients with reablement or intermediate care rehabilitation where there's a much better transfer of goals. But I mean, it is a huge problem. That is the whole handover within hospital, but between services is hugely important. And when I was, our integrated care work, whilst I think one needs to look at methodology as well, is just getting ourselves, GPs, community psychiatrists, etc., in a room talking to each other is a huge start. Because again, we'd stopped doing that. Just specifically on the AMBER subgroup, we are sort of piloting a community AMBER care bundle with the sort of GP sort of modifications, things of which assessing a patient within 4 hours equals 24 hours and so on. But I think that's, for this group of patients, that is a huge quality challenge, and obviously one of the reasons that we see so many unplanned readmissions, which are one of the major costs in our health system for those patients.
Great, thank you very much, Adrian. You come on down, Warren. Do you want to get organised there? Because we're not going to let you off the hook. Fran has another question for you. So while Warren's getting ready, we'll let you answer this question.
We're getting quite a lot of tweets on the theme about this, actually. Someone's asked, does more paperwork and pathways cause extra stress on understaffed geriatric wards? Other people are saying it's quite straightforward to put a process in place, but actually implementing it is much more difficult.
And, this is a quality improvement journey, isn't it? What I would say is chaotic process, which is traditional clinical practice applied to these patients, is hugely stressful, hugely inefficient, and hugely costly. So I think as an add-on to, if you like, the default position, what I've seen, I see the patients, say the AMBER process actually takes a lot of the stress out of it because everyone, including the patients and the care, are calm because the advanced care planning, that's been taken forward. Again, it's a bit like, could we imagine a world when you can get rid of all of that? Perfectly possibly, but I think, and whether, my personal reflection is how very stressful the current system is. But, Paperlite, and we try and do it mostly web-based these days, but we'll see.
Adrian, Mark, thank you very much indeed. Now, our next speaker...